Good afternoon, everyone. Today is Thursday, May 30th, 2024 at 3 p.m. Central Time. Welcome to the second web briefing of the Iowa Advisory Committee to the U.S. Commission on Civil Rights. My name is Henry Hamilton III. I'm Vice Chair of the committee, and I will be chairing today's web briefing. I will now conduct a roll call of members present. Committee members, if you are joining by phone, please press *6 to unmute yourself and *6 to place yourself back on mute until I call you during the question and answer session. Chair Juan Garcia is excused. Kyle Bergeson.
Here.
Paul Fessler. Katie Fiala. Adam Freed. Cynthia Kohler. Stephanie Munsterman.
Present.
Alan Ostergren. Donald Roth. Thought I saw Donald on here. Okay. Donald, are you there? Okay. All right, we have a quorum and we'll proceed with the meeting. I do want to make one clarification. I said this was the second web hearing. This is the third web briefing. Also present are commission staff Anna Victoria Fortes, who is our designated federal official, and Corrine Sanders, our support specialist. The United States Commission on Civil Rights is an independent bipartisan agency of the federal government charged with studying discrimination or denial of equal protection of the laws because of race, color, religion, sex, age, disability, or national origin, or in the administration of justice. In each of the 50 states and the District of Columbia, and more recently established the American territories, an advisory committee to the commission has been established, and they are made up of bipartisan persons who serve without compensation to advise the commission on relevant information concerning their respective state. Today is the third in a series web hearings examining access to mental and behavioral health care for K-12 students. These meetings will help the committee understand the current issues in assessing mental health care for K-12 students and the civil rights implications, if any. Following today's meeting, we will determine if we will host additional web briefings. Based on information collected through testimony, the committee will draft a report that will include findings and recommendations that will be shared with the United States Commission on Civil Rights. The commission will then forward these recommendations to the appropriate federal and state entities. I'd like to share at the outset, this meeting is being recorded for the public record, and the web hearing recording will be available on our public database. Please contact Anna Fortes at Fortes, AFORTES at usccr.gov if you wish to obtain those records, or if you like to receive notification of future meetings. In a moment, I will invite our speakers to present for 15 minutes. Afterwards, advisory committee members will have an opportunity to ask questions. This question and answer session is reserved for committee members only. After the committee question and answer session, there will be a public comment period where members of the public will be given an opportunity to share their perspective and opinions on this topic. If you are not able to share your full remarks today, please email your remarks to afortes, AFORTES, at usccr.gov for inclusion in the committee's proceedings. After the public comment, the committee will then move into conducting committee business relating to planning future briefings. If you are a panelist or a member of the public, you may leave or choose to stay in the call if you wish, as all of the advisory committee meetings are open to the public. Before we move into presentation, I want to remind everyone again that this meeting is being recorded and it will be transcribed for the public record. I ask that you please state your name when speaking to assist with transcription. Closed caption is being provided for today's meeting. To view closed caption, check the CC icon in the lower left corner of your screen. Though some of the statements made today may vary from personal perspectives, we want to ensure that all invited guests feel welcomed and do not defame or degrade any person or any organization. As the chair of today's meeting, I reserve the privilege to cut short any statements that defame, degrade, or do not pertain to the issue at hand. Any persons or organizations that feel defamed or degraded by statements made in these proceedings may respond and submit written statements for inclusion in the proceedings. I urge all persons making presentations to be judicious in their statements and remain on topic. The Iowa Advisory Committee appreciates the willingness of all participants to share their views and experiences with this committee. We will now proceed to the presentation portion of our meeting. Today, we will hear from 4 speakers with unique perspectives in their respective fields on these topics. Presenters, please aim to stay within your allotted speaking time and reserve additional talking points for the question and answer session in case you are not able to address them within that time. Anna will be sending you messages through the chat box to let you know when you are near the end of speaking time. I do want to comment for the record that Donald Roth is present. He's having issues with his sound, if that can be reflected in the records. With that said, let's begin today's meetings. Today, we will hear from Ann Harris Carter, Health Equity Manager at Linn County Public Health, Cindy Yelick, Chief Administrator at Heartland Area Education Agency, Tami Valline, High School Counselor at Perry High School, and Tonya Hotchkin, Vice President of Clinical Prevention Services at Tanager Place. At this time, I'd like to invite Ann Harris Carter to begin. You may go ahead.
Thank you so much, Vice Chair. Again, I'm Ann Harris Carter, and I serve as actually Health Equity Program Manager for Linn County Public Health. I want to thank you for the opportunity to share today. I consider this a great privilege. And there are 2 parts to my presentation. First, I'm going to talk about my own lived experience with mental illness, and that will hopefully help provide an understanding of the work that I do. And so the second part will be a project I am leading as part of my role with Linn County Public Health. I also hope that both parts will help the committee consider multi-generational implications as you evaluate access to mental and behavioral health care for students in K-12 schools. So I have taken medication for a bipolar type 2 since 2008. That means 16 years since first hearing the diagnosis. That's 16 years of trying different mood disorder medications, 16 years of trying different doses and trying different times of day for taking those doses, 16 years of different therapists and different psychiatrists. And so It's only been in recent years, however, that I have begun speaking more openly about my experience. And I have to tell you, that has been a game changer for me in conversations with my adult children, whether we're talking about my health or theirs. I also have two granddaughters. One is 13 and the other a year and a half. And so while the 13-year-old may not know the full scope of what living with bipolar type 2 means, she can relate to the fact that Grammy sees a therapist and Grammy takes medication. And one of the things that I always like to say at the outset, nobody needs to know all the details anyway, including my children and my grandchildren. So I should explain that bipolar is a brain disorder that causes shifts between high and low moods. With bipolar type 2, the high moods are characterized as hypomania, and the low moods are characterized as depression. And so bipolar 2 can actually look like depression, but the treatment is different. So if it is misdiagnosed, treating bipolar type 2 solely with antidepressants can actually trigger mania or hypomania. With mental illness, as you probably aware, the stigma is such that on average, people wait 10 years before seeking help. That statistic does apply to me. Prior to the diagnosis, I thought the root cause of my mood changes was premenstrual syndrome or PMS. So I did not discuss it with my doctors, and I did not imagine that my cycles were notably different from what other women experienced. And instead, I spent years thinking I needed to power through because that's what smart, strong, successful women do. Upon hearing the diagnosis, I hid my treatment in my personal and professional life for another 10 years. I discussed very few details with those closest to me, and I told very few people outside of my family. The stigma literally felt oppressive and silence felt safe. I admit I was proud of my career accomplishments, part of a senior leadership team in a Fortune 200 company, meeting with students, faculty, and administrators from leading universities around the country, and traveling coast to coast to deliver presentations and keynote speeches. Work is where I faked it the most. I absolutely perceived that bringing my whole self to work would jeopardize all I had achieved. Ironically, it was at work where I discovered the toll of hiding my diagnosis. My company sponsored a workshop that involved much needed reflection about how I showed up at work, how I showed up at home, and how those aspects of my life intersected and impacted my effectiveness. So not only was I hiding my diagnosis, but I was using a tremendous amount of energy doing so. That's really to say I was wasting a tremendous amount of energy. And I did not see at the time how my efforts to hide things sometimes impacted my interactions with others in, frankly, less than positive ways. I had confided in a couple of coworkers and gradually confided in more, and those one-on-one conversations gave me courage and created safe space for me at work. And it didn't take me long to realize I was not living alone with mental illness specifically, or managing mental health in general. And I realized it's way too easy to get caught up in the false narratives. Oh, I'm not that bad, or oh, I can handle this, because we live in a society that reinforces those narratives. Just deal with it or get over it. So I offer my testimony now because I know how detrimental the stigma can be. And I've discovered that there is tremendous liberty in sharing. With each sharing opportunity, I learn more about what, how, and when to share. Before long, I was sharing not only at work, but sharing my story at church and in the community. And then ended up making a career pivot to join Linn County Public Health as Health Equity Program Manager. And one of the projects that I am leading is directly related to mental illness. So I just, as we make this transition, we're going to pull up a few slides that I'd like to share. But it's so important to me to talk about my experiences. Again, easy to spare lots of details, but that's the way we end stigma. That's how we normalize the conversation. And I think Anna's going to pull up, thank you. So I want to give you a short timeline, an abbreviated timeline of Linn County Public Health and that led up to this project that I'm going to share. So in 2020, the Board of Health declared racism a public health crisis in the summer of 2020. And we remember what was happening during that time, the social uprising, particularly following the murder of George Floyd in Minneapolis, but just that heightened sensitivity to racial justice. And with that declaration came a commitment to create an Office of Health Equity. My position came to fruition in 2022. In 2023, I launched a health equity work group, which is what I'm going to be talking about. But I also want to mention that this year we released our health equity strategic plan, and we'll go to the next slide. What I want to share on the next slide is with the Office of Health Equity, we have this purpose statement, and it is simply to seek to remove barriers and create solutions, right? So you've got to break something down, but you also have to replace it with something that's meaningful. And how do we create those solutions? We create those solutions by bringing together our partner organizations, you know, those who have programs and services that they deliver, who may have formal arrangements with public health, as well as bringing together people who face greater health risks. And that's what it takes to make Linn County a place of good health and a place of belonging. If we look at the next slide, we have a map. This really became the genesis for a work group. In the fall of 2022, I went to the CEOs of the two hospitals here in Cedar Rapids, St. Luke's Hospital, part of the Unity Point system, and then Mercy Medical Center, and then also Eastern Iowa Health Center, which is our federally qualified health center, and said, I need to understand what this declaration means. I want to make sure that it's not performative. I want to make sure that we're actually making some actions, and I can't do that alone. And ask them each to identify folks from their leadership that could participate in a work group over an extended period of time to understand, what does health equity mean in our individual institutions? What does health equity mean for us collectively, and how might we collaborate? What this map is showing you is life expectancy at birth on the left. The big picture is all of Linn County, but this inset is really 3 neighborhoods in Cedar Rapids, in the center of Cedar Rapids, where our 4 institutions live. And the purple, the darkest color, is the lowest life expectancy in Linn County at 66 years. And if you look at the larger picture, you can see the higher range is 83 to 85. I think, did I go away? Am I still there? Okay. So a difference of 10 to 20 years for these neighborhoods surrounding our institutions. So it kind of begs the question, surely we can do better. The last thing I'll say about this slide before we go to the next one is, if I've got a map up on my wall that's from the 1930s, the Homeowners Loan Corporation redlining map. And if you were to overlay that with this, you would see similarities, which is really what you see in I think most cities that have redlining. We're going to go to the next one. So let's go to the next slide. And there are really just a few words that I want to reference on the slide for today's purposes, and that's narrative change, and then racial healing and relationship building. I was introduced to this framework, which originates with the Kellogg Foundation in a convening of jurisdictions that have declared racism a public health crisis. So let's go ahead to the next slide, because again, I want to just focus on narrative change and that racial healing and relationship building. So part of the deal in working with the healthcare institutions was, okay, we're going to come together and we're going to apply this framework to our work, which means, first of all, there has to be a foundation of trust in what we do. The reality is we work with hospitals that have competitive service lines, not in everything they do, but that's a part of the nature of the business that they're in. And so we wanted to make sure that we could talk about those things candidly and address points of friction. But beyond that, we said, okay, so in order for us to pursue narrative change, that means, what does that mean to us? Using common language, it means we will identify areas where we can collaborate, but we won't begin to problem solve until we bring alongside community members to participate in the effort with us. And that means that we will be using stories to illustrate data and taking care not to use terminology to weaponize any lived experiences. And then certainly the racial healing and relationship building. And ultimately, this is all about transformation. That's what the TRHT framework is all about. When we go to the next slide, at the end of several months, the initial work group agreed that our focus would be on mental health, on mental well-being, and more specifically, seeking to understand what impact racism has on mental well-being in our community and how the local healthcare system can provide culturally informed care and promote social belonging. And so we'll look at the next slide. I just want to give you a sense of some of the models that we use. So we were able to identify and invite community members to come on alongside to expand our work group that started last fall. And they all identify as having lived experience with racism. In our case, they are also all identifying as Black or African-American or biracial. But we wanted to align our vocabulary. And so this is a model on racism. So we talked about not just interpersonal racism, but also what does it mean for individual organizations? What does it mean at an institutional level? And then what does it mean structurally, for example, within healthcare? And we also talked about the presence of internalized racism. On the next slide, we're going to see another tool that we use, this racial iceberg. We used this to be able to discuss what is our knowledge of history in this country and where did we learn that? And so including when was the first time that we had a teacher that didn't look like me or didn't look, look the same as me. And so these tools from the racism model, the racial iceberg, some other frameworks gave us the ability to frame conversation and dialogue amongst our work group. On the next slide, and I think I just have two more to do before I wrap up. We had our work group kind of conduct sort of informal interviews. The idea was that everybody would talk to a handful of people using the same set of discussion prompts. And the prompts, there were some that talked about their sense of belonging in their neighborhood and a couple other questions. But I like to feature this one. If you or someone you care about needed mental health services or support, 3 questions. First, would you be comfortable seeking help for yourself or them? And I'm just going to look at one number in each category. That 18%, not likely. So that's a small number. But the other side of that equation is that most people said, yeah, it's either somewhat likely or very likely. Then the next one, would you know where you or they could go? 24%, not likely. Okay, so about a fourth of the people said they weren't sure. I like to notice that or point out that that's an increase from the 18%. So we're starting to see a shift in the numbers, but still the vast majority of individuals said that it is somewhat likely or very likely that they would know where to go. And third, would you be able to find a provider who acknowledges and respects cultural differences? That first number jumps to 37%. 37%. And so this informal survey really presents the case for we've got work to do in our community. And that's the next part of, this work group's efforts. And if we'll go to the last slide, the question that we're kind of wrestling with now is, what demonstrates that a space is expressly created to eliminate the impact of structural racism? How do you know whether you're in a single room or a building or a conference room or an event that somebody was thinking about structural racism and how that impacts our community. So this summer, we'll be mapping out some community-based services that we've identified and learning more about them. We'll also be looking at health delivery models that center culturally formed care here in the state as well as around the country. Co-College is a small private school here in Cedar Rapids, and we will be partnering with a research team of students from there with a professor as their advisor to take that informal survey that we did and turn it into something that will be statistically significant for us. And then the hope is that by spring of 2025, we've got our long-term strategic plan. So again, I offer that up because yes, your focus is on K-12. I also want you to consider, what about the parents that are working with those students? What about the administrators that aren't trained mental health providers, but encountering challenging situations day in and day out in our schools? I guess I'll close with, and you probably have heard, it seems like the most often quoted statistic about mental illness is that one in five adults in the U.S. will experience mental illness each year. I sometimes talk about the silver lining of COVID, which is COVID became a time when we ended up talking much more openly about stress and anxiety and depression, whereas in the years leading up to COVID, 1 in 10 adults reported experiencing symptoms of anxiety or depressive disorder. That jumped to 4 in 10 during the first half of 2020. And so it's sort of behind us, but I know it's still with us. And I know this group will be looking at other factors that are impacting our youth today. So thank you very much for the opportunity to share.
All right. Thank you, Ann Harris-Carter. We'll now hear from Cindy Yelick, Chief Administrator at Heartland Area Education Agency. You may go ahead.
Good afternoon. Thank you so much for the opportunity to meet with you today. I'm going to take a few minutes and just do a very short overview on what the AEAs are in the state of Iowa, and then what our mental health supports include, and then talk a little bit about future planning for the AEAs. So you could, there we go. So in Iowa, we have 9 area education agencies currently. They began in 1975, and they were really set up to provide equitable and efficient services across the state. For those of you who have been involved in the education conversation for multiple years, you know that in the mid-1970s was when we passed our first federal IDEA law. And so the inception of the AEAs were really about providing those special education services equitably across Iowa. We do serve all public schools and all accredited non-public schools. So what do the AEAs do? We provide services in 3 major areas: special education, media and technology, and education services. And we're going to take just a minute to talk about each area so you know how this impacts our services for social emotional learning, mental health. First of all, in special education, we can start working with a family if their child is born and spends time in the NICU. So they can be assigned an AEA service coordinator. And if a student ends up qualifying for special education services, we might support that family and that student through the age of 21. But for the topic we're talking about today, we help with identification for special education supports, and we also can provide direct support from a school psychologist or a school social worker if it's written into a child's IEP or individualized education plan. So we do have practitioners who are working one-on-one individually with students. Also, their IEP may include supports for classroom or peers to help understand what will help them thrive and succeed in the classroom. So sometimes that means a psychologist is working with a 1st grade or 4th grade grade class to understand, you know, what their peer is experiencing or how they might be a better friend or be more supportive in that area. Our next service area then is media and technology, and this does not have as many focus supports for the topic we're talking about today, but we are seeing for kids today, the issue of technology really is impacting mental health in a different way than we ever thought about it before. Anxiety with their absolute 100% connection to peers at all time and know what that is, how cyberbullying is impacting kids' mental health. So we do have some services in this area that just help schools navigate maybe what policies they should be thinking about having in place to protect kids from cyberbullying, how they can teach kids about appropriate use of technology, and just thinking about how that all comes together to impact a student's mental health. And then our next area of service is AEA education services. This is where we do a lot of support for teachers, and we also provide social workers through this. We have a lot of different mental health supports, and our next slide then is going to show you kind of how that is tiered out across our system. So at Heartland, we have a multi-tiered system of supports. If you look at the bottom of the pyramid, and in the slide deck that I know you have access to, the next slide is a direct link to this. And so if you want to follow up, because I know it's a little hard to read on the slide, you'll be able to click into that link and see the pyramid more closely. But our foundational piece is really about how do we work with adults. And when you think about our system is set up to focus on K-12 schools. So we start, we work with kids that are in preschool all the way through high school graduation, but we are really not positioned to work with families or provide direct support to parents of students that are experiencing mental health needs. So when you think about foundationally, where are we with adult supports? Those are really aimed at teachers and school structures. So we have several trainings, youth mental health first aid, how do you set up and support a trauma-sensitive classroom, strategies that teachers can use with individual students, such as check-in or check-in connect. So that foundational part of the pyramid is on how do we help teachers build inclusive classrooms, and how do we work with all kids in the classroom to be sure that we're having the most emotionally supportive, sensitive classroom that we can. Then as you move up the triangle or the pyramid, you see that things become more focused on individual students and individual student learning. So as you move up, you see that we start to provide individual student supports. Some of these things might be direct support of students. They might have a goal written on their IEP saying that they need a 30-minute check-in with a school psychologist once a week to help them learn how to de-escalate or how to cope with anxiety and a stressor as they're experiencing that within a classroom. There also might be a student who has who does not have outwardly presenting behaviors. And these have been the ones that have been hardest for us to figure out how to support in the schools, because they often go undetected or undiagnosed for a long time. When Ms. Harris-Carter was talking about that 10-year gap of seeking help, unfortunately, I think in the K-12 system, we have students that go for several years before they're old enough to realize they need help and before a teacher might realize they need help. So that, I think, is a real gap in our system for those kids that don't have externalizing behaviors. So the other thing that we do in direct student support area is in rural Iowa, we have an absolute shortage of providers. And so the AEA system has worked to hire school social workers that can be shared across school districts, and they can help provide that either once or twice a week immediate support from a school social worker. And that person can also help them access community resources if those resources are present. And then another piece of this direct service to students is that across the state of Iowa, we have some therapeutic classrooms that have been set up in collaboration between a school district and the AEA. And I think it's important for the committee to understand that the way this has been supported in our state is that the legislature approved a series of grant dollars. So schools could apply to be a site for a therapeutic classroom, and then they can work with either a consortium of districts to serve students in that area, or they can have a classroom that's set up just for students within their resident district. And I think a reason it's important to understand that means because it was that grant system, it was not necessarily set up or did not play out to be a systemic look across Iowa. So you'll have pockets where students might have access to a therapeutic classroom that's helping them with their social emotional needs. But they could be in a district 60 miles away that does not, and the students do not have that same access, because it really has been about where those grant dollars have flowed and where a district was wanting to step forward, perhaps with the support of the AEA, to establish that kind of learning environment. The last area, or that kind of tip of the triangle that you see, is what we call those more intensive or tier 1, tier 3 supports. And those play out in two ways. One, as direct support to students. So we have students with very involved IEPs that we're helping support those goals, and we're helping them try to thrive and access FAPE in their local district. And sometimes that also means we're helping identify, is there another education setting where they will be more successful. The other area that we're providing support in that way is through our crisis response team. When a school community has a tragedy, such as loss of a staff member or a student death, we have a team of mental health professionals that goes out and they assist in that community for 24, 48 hours. They're kind of doing that initial triage, meeting with students, meeting with adults, and then helping them get paired to community providers if that's what they need long term. For some of the committee members that are in Iowa or close to Iowa, this was a service that was accessed for the Perry district. And that support stayed in place much longer than 48 hours. Our typical time in that situation is about 48 hours to get people connected. And one of the things I think has been really a nice connection is that we have been able to hand off to then the regional mental health system, or depending upon resources in the community, to local private providers. So that's somewhere I think there's been a really nice connection in communities, and I would want to hallmark that as there are some places that system of support is going really well. So those would be kind of that initial first blush. And what I wanted the committee to understand is that there is a network, starting with just how we support inclusive and supportive classrooms, moving up all the way to then how do we support individual students who have very intense needs, or communities who are experiencing a crisis with which they need help. The second part then, and we can stop displaying the slides, that I wanted to talk about is, as you think about our work, working with families with students as young, well, from birth, but mostly from age 3 all the way through 21, when you think about our connection to the community and the regional mental health providers, I wanted to share some places that we're seeing there's perhaps a gap in our system. First is, as Ms. Harris-Carter pointed out, that support for families. So sometimes that is because they have a child with needs, and they're really trying to understand how to navigate that system and get the right supports. But sometimes when we're working with a child that has needs, their parents do as well. And we don't really have a good mechanism to find supports for the parents. So that family piece, I think, is really critical for us to think about as a state. The second thing is we find more and more that we don't have a true continuum of supports for all kinds of student needs. So in some cases, we have the therapeutic classrooms we can have a student referred to. But as I said, we don't have a good system across the state. But the other thing is most of those programs are set up to deal with a really specific or focused type of learner. And so if a student doesn't fit what that program is about, then there is kind of nowhere else for them to go. We have examples of students who are in their resident neighborhood school, and they might have a teacher and an associate working with them day in and day out, just to try to help them get through the day and get their education needs met. But we're really not tapping into what's going to help them work through their mental health needs and really, I guess, make progress in that area. And so we definitely need a bigger continuum or a greater continuum that can help more kids and help them with different kinds of needs. So that's a second area. The third thing is when we in schools are seeing a student in crisis, though sometimes the way we're having to deal with that is by accessing law enforcement. So maybe a sheriff's office is called, they come, they try to de-escalate a student if the school has been unsuccessful, and they might transport to a local emergency room. If you think about just the trauma of that for the student, for the family, it's pretty significant. So that initial crisis and how we can support that in schools is something we need to think about. There's a huge disparity in what access students that live in rural Iowa and who are living in poverty have access to versus if you are in a metro area and your family happens to benefit from a really robust health insurance plan, or you can pay for private providers. So that access across both rural Iowa and students in poverty. And the third area for us really goes back to that foundational piece on the triangle. In our state, there's been significant discussion legislatively about what is appropriate to teach in that social emotional learning continuum, and that focus is being tightened. So that is causing us to reflect and refine and step away from some of the things that we have been historically supporting schools to engage in. The last thing is funding and structure for the AEAs has changed significantly as a result of the last legislative session. And so those supports that have been accessed through education services or non-special ed IEP driven services are probably going to change in the future. So with that, I'm happy to transition to our next person. I think Anna gave me the time's up.
Well, thank you, Cindy Yelick, Chief Administrator at Heartland Area Education Agency. We'll now hear from Tami Valline, High School Counselor at Perry High School. You may begin.
Thank you, and thank you for this opportunity. And as Cindy mentioned, I'm one of the counselors at Perry. We did recently, January 4th, have a school shooting. And so mental health has been at the forefront. It was previously, but for sure since the incident, and looking at different ways to meet student and staff's emotional needs. So if I can get my slides. Yeah, so just some of the challenges and triumphs we've had since January 4th, I'll speak to just a little bit here. So some of the themes that we are seeing with difficulties with our students is that we have very large wait lists for students being able to see a therapist. Luckily, the AEA has been able to help some with that. And then we've had some other agencies that have been able to come in and help us. And so that's helped. We have a lot of students that are uninsured or underinsured or uninsured. And so it makes it difficult for them to be able to access services. And then some of them that do have, hang on just 1 second, I'm so sorry. Sorry about that. Some of
no
those
worries.
students that are able to access, their co-pays are so high that the families just can't really cover that. And then a lot of our families in our district, and we are a lower income district, they just don't have reliable transportation to get to other communities that might have more resources available. A lot of our families are also undocumented, and so they're unable to get driver's license. So it's just not safe for them to be able to travel, lack of gas money, those kinds of barriers. And then we also have kind of a subset of families that have some religious beliefs that prevent them from or kind of get in the way of those students being able to access mental health services. And that kind of goes along with that last point there. A lot of our students are first generation to even graduate from high school. And so a lot of their parents are uneducated about just mental health and what that is and what resources are available to help their students heal or get better. And so all of those kind of together present a lot of barriers for our students to be able to access mental health resources or supports. Luckily, again, we've been really fortunate since our incident to be able to get a lot of outside support into our building this semester. The area education agency was key in coming in and providing supports right away and for an extended period of time for our staff and our students after the shooting. We had some outside agencies that have come in and are still working in our building even through the summer, meeting with some of our students. We had the Department of Education come in and bring some folks to help as well with some recovery efforts. And, a concern that I have that I'll speak to here a little bit more in depth shortly is just that, as time passes, that some of those supports are going to be going away. And, we definitely still have some staff and students that are going to be in need of those services. And so funding is going to be kind of an ever-present issue for us moving forward, I think, to be able to keep those supports in place. In terms of populations that are impacted when we talk about mental health in schools, really it's all of them. Mental health, just like physical health issues, cuts across all populations. We do see kind of an uptick for students needing mental health resources where there's little or no family supports, where there's been previous traumatic experiences, and or when students already have a mental health diagnosis coming into high school. Those are definitely populations that are impacted more heavily when it comes to needing mental health supports. And then, of course, any of our students or staff that were on site during the shooting or were in close proximity to what happened or have family members that were, those students and staff are also, heavily impacted and in need of a higher level of support. There's some questions about just kind of the differences in accessibility to mental health resources and supports. And, where I'm from, Perry, Iowa, is just about 30 miles west of Des Moines, so kind of central Iowa. And Iowa in general struggles a little bit in our rural communities to be able to access quality mental health providers. And Perry is no different. We're not too far from Des Moines, but just far enough that it's difficult for a lot of our families to access providers in Des Moines. And so online services or telehealth services have become a lot more popular for many. I see with some of my students that that works beautifully and they are comfortable with that online support. However, a lot of them also don't like that, and they much prefer in-person therapy or counseling sessions. And so although that's helped some, we still need more providers willing to do the in-person therapy services. And so, what needs to be done to be able to help bridge kind of the gaps that we're seeing with the needs in mental health and where we're at right now, definitely funding. It would be great, just like, a lot of schools have certain positions that are required across the state, like districts are required to have a certified counselor, for example. It'd be great if they could also be required to have a mental health therapist on staff or a social worker, so that we could alleviate some of those wait lists and barriers for students being able to access help. And of course, that costs money. One of the last questions I'll speak to here is, if funding was not a barrier, how might we be able to access? And that's really difficult because, really what you need is people, qualified and trained people that are able to provide a high level of care, quality care in the area of mental health for these students. And so to do that, it's costs money. One thought that some have discussed is, trying to access people, maybe retired folks or people that are just willing to volunteer an amount of time per week or per month to provide some of those services. Of course, that gets really tricky. And unfortunately, in the area of mental health, salaries are not amazing. And so, people wanting to give additional time for free is going to also be a challenge. But we continue to look at, different grant funding, different sources, even private donors to help with some of our, we have a student needs fund where, we can use some of that fund to help families pay co-pays if that's an issue for them. So there's some different, creative ways that we can look at trying to bridge those gaps. But it's a lot of work and it takes a lot of time to coordinate a lot of those efforts. And that's time that, most of us just don't have because we have another job to do within the school. So I think it's very valuable that we're looking at this and sharing insight on this topic, because it's definitely one that's important and one that we were kind of looking at even prior to the shooting. And since then, it's just been a really big issue for us being able to help all of the people that need to or are asking for additional support be able to access it.
Well, thank you. Thank you, Tami, Valline High School counselor at Perry High School. We'll next hear from Tonya Hotchkin, Vice President of Clinical Prevention Services at Tanager Place. You may go ahead.
Okay, thank you so much. I know that Anna might start a PowerPoint here for us. Now I can bring up some visuals. I'll give her a second, but I want to appreciate and share my gratitude to be here to talk about this incredibly important topic. When we live day in and day out of that regarding access to mental and behavioral health care, we see the impact. So getting a chance to tell some of the stories experienced by those so incredibly impacted by this is an honor. So, okay, so if we want to move to the next slide. I don't know, can I move them, Anna, or are you just going to move that? Anna?
Hi, Tonya. I will give you access right now.
Okay, wonderful. Okay, so I am going to then open up my PowerPoint, it sounds like. So I'm going to share my screen here and share with you some of the information that I have. Okay. So one of the things about Tanager, we're located in Cedar Rapids, Iowa. We do have a site in Johnson County, so in Coralville, Iowa, and also have a DBA under a scent therapy group in Marion, and then also have Camp Tanager. But really, it's located in the corridor of Linn County, although we do have services in many of the surrounding counties. We've been around for a long time, an organization that was started in 1879, actually, as an orphanage for children, and has really stayed close to that mission ever since then, with a new mission here in the last decade to provide services to youth and families that inspire, empower, and heal. So primarily looking at approaching the work across 3 different pillars. We really focus on prevention, treatment, and outreach.
I'm sorry, Tonya, to interrupt.
No,
Can you
that's okay.
switch your view to the a different view? It's showing the presenter view right now.
Yeah, absolutely. So let me share the right screen for you. Okay, is that showing?
Yes, it looks
Okay,
good. Thank you.
wonderful. Yeah, of course. And so we have a variety of services. We serve over 4,000 youth and families every year across those continuum of services. We are about a $22 million organization with 300 FTEs, as that gives you kind of scope and reach within our practice. Prevention services that we really focus on throughout the history and continue to offer yet today is an after school and summer program called Freedom Schools to try to mitigate reading loss for youth attending middle schools in the Cedar Rapids area. We offer Camp Tanager, which is free campership to children who otherwise would not afford a summer camp experience. We have a social skills group looking at after school intervention for kiddos who have social skill deficiencies within their daily functioning. We have an LGBTQ+ center, which is a prevention approach to creating a safe space for those who identify and their allies. And then there are some acronyms too that I'll explain, but we have something called Infant Early Childhood Mental Health Consultation. So that is through our partnership and relationship with ECI. And so we offer intervention and consultation to daycares who are looking to improve their practices for those attending their centers related to mental health and behavioral health needs. And then we have a lot of expressive arts programming at Tanager. The reason this is under prevention is because the state of Iowa actually doesn't reimburse for expressive arts fee-for-service intervention. So what I mean by that is that people will graduate from an institution with a bachelor's degree or a master's degree with art therapy, music therapy, drama therapy, and they are not able to be licensed in the state of Iowa, which means then they're not able to be reimbursed for their services that they provide. And so that is a grant funded programming in Iowa because we don't have a licensure status for those domains of expertise. We have a lot of outpatient services. So we have an outpatient clinic that has a psychiatrist, a psychologist, some other med providers, and about 20 to 25 therapists doing a variety of different therapeutic approaches and interventions. Additionally to that, we are in over 11 districts and over 65 schools across the Cedar Rapids and surrounding communities with therapists embedded in schools. We have a unique approach to school-based therapy, meaning that our therapists are never in more than 2 buildings. So they're either 100% of the time in a building or split 50% in one building, 50% in another. The reason for that is because our therapists are really embedded into the MTSS structures and a part of that school culture, and really probably identify more with the school staff than they necessarily do Tanager because it's part of their day-to-day. But we also found throughout our journey of school-based therapy services that shared logic model and shared business model with schools not only was more affordable and equitable for schools to be able to pay for the service, but also allowed us to have greater outcomes and outputs for students in those buildings, because then being embedded in that created their own therapy space with therapy supplies that are really allowed them to do the practice that they have expertise around in a way that wasn't a model that was between kind of 11 or 12 different schools within a given week, which I think for a lot of therapists felt very daunting and was not a service that they felt was being as helpful for students. We also do psychosexual assessments and psychological evaluations. Additionally, we have community-based services. So we're just starting multisystemic therapy, which was approved through legislation of almost a year ago now. And that is an in-home therapeutic approach. And then in-home services more at a bachelor level, so case management or coordination of care, which is behavioral health intervention services, and then pediatric integrated health homes and ICM services. Lastly, we do have residential treatment. So we have psychiatric mental health institution for children, which is also known as a PMIC, as well as an ICFID population being served here in residential care, and then just launched here within the last month a crisis house. And then lastly, within a partnership with our East Central region, we also house therapist within the Linn County Juvenile Detention Center. One thing that people may not know is that when youth actually enter into the detention center, they lose all of their insurance because it is a state-funded program. They lose any Medicaid that they had. So the inability to bill for therapy or medication management services, instead the detention center would have to fund that for the youth, and with competitive budgets, often some of those services were going unmet so that they could run daily operations. So within that partnership, found it really vital and important to offer that service. So it tells you a little bit about our scope and practice, if it gives you an idea of now what we see within this work as some barriers and needs. We obviously know, and I'm not sharing anything new to any of you, the prevalence of mental health for youth. The suicide rates are increasing, and we know that access to treatment has decreased, especially for those in marginalized populations and those with Medicaid as their primary insurance entity. And I share that because I think it's going to go a lot into what we need as systems and structures to better improve our mental health. So a lot of the things that we see as barriers and threats to both access and that of engaging in services is the financial barriers. I know you've heard other testimony related to this, but the type of insurance that you have and the type of mental health coverage you have within that insurance deeply influences what you're able to access and how frequently you are able to access it. We have a lot of families that land in the middle of the income level, which means that they may not qualify for Medicaid or Hawkeye, but they have a high deductible plan or a large copay that is not affordable to them. And there are no systems in place from a secondary insurance level for many of these families in order to afford mental health coverage and treatment. Similarly, there are a lot of families that may qualify for Hawkeye, which is, if you look at Medicaid being within the poverty threshold, Hawkeye is kind of the next step trying to catch some families who do not qualify for Medicaid, but then Hawkeye does not have many of the services needed covered within the plan. So for example, they can't access pediatric integrated health homes, which is case management and coordination of care. They can't access behavioral health intervention services and several other services. Similarly, there are a lot of denials and or slow authorization. So a lot of the structures in place for those with Medicaid require pre-auth or authorizations for services into whether that be PMIC and residential services, that for BHIS services. And frequently there can be slow authorization process or frequent denials that limit the access to these services for youth and families, or cut them off from services that are still deemed necessary, and are medically being recommended by those deemed as experts in the field. But then the burden falls on the family to do an appeal process that often can be very burdensome and over stressful for families who are already having a lot of struggles related to access and treatment. As many people already said, we have a lot of resource deserts, so we lack a lot of providers and resources in rural areas. And there's not any current incentives to provide these services in rural areas, which is not helping us continue to improve that access for those within those regions. The type of insurance providers accept is another large barrier. So I'm going to try to do this in a very fast way because I know I only have so much time. So legislation changed about, I think, 4 years ago that looked at how therapists can bill fee for service, which included the level of licensure you have. So as a therapist, when I graduate with something called a temporary license, or I am an LMSW, so I'm at a master's level. And back, 5+ years ago, I could only bill Medicaid clients with that licensure status. And so a lot of these providers were going into nonprofits, and as oftentimes it was the only option for employment, they would do their 2, 3, 4 years of work, and then they became independently licensed, and then were able to then move on, often frequent times going into private practices, and choosing at those times to not be credentialed with Medicaid and only serving those with private insurance like Blue Cross Blue Shield, United Healthcare. Well, legislatively, I think we changed things because we wanted more providers to have more career and employment opportunities, which was a beautiful thing to do for the field. But unintentionally, what we found is that then providers graduated, and because now they can bill any insurance type under the NPI, the National Provider Identification Number, of an independently licensed therapist. So I could have a private practice, bring on a temporary licensed therapist. They can bill under my NPI, and I get typically a percentage of what their reimbursement is, and then they get a percentage. But that now allows them to work in my private practice versus going into the nonprofit sector. And a lot of the private practices in the state of Iowa often do not take Medicaid, simply because it can be more burdensome to get credentialed. The AR is much higher, so the accounts receivable is much higher. The reimbursement rates are less. And so we have a lot of graduates then where they were often required to go into non-for-profits are now going into these small private practices. And now these small private practices are not taking Medicaid clients, which continues to increase the gap for access to care for those marginalized populations. So the type of insurance providers accept is a huge barrier to those on Medicaid or Hawkeye being able to access at the same ability that other insurance holders have, creating more disproportionality. Similarly, a barrier and a threat to access is the fee-for-service approach. There is a sentiment or feeling for providers who do serve Medicaid clients that they would like to take a more systems or holistic approach to therapy, meaning that they would like to collaborate more with schools or maybe their juvenile court officer or HHS or other people to coordinate the therapeutic approaches needed for them due to the system impacts that these families frequently have. But because the way that we structure fee for service, there are only so allowable CPT codes to bill, which often means that these providers are doing other things for families that don't then get reimbursed, which then is a drain on them as providers to choose to do something for free or to choose to do something for reimbursement only for their own livelihoods. Medicaid client needs, as I said, oftentimes can be greater, or the diagnosis can be greater to deal with as a therapist. If I'm serving a client with a PTSD diagnosis that looks very different than, and that's a trauma diagnosis, looks very different than if I'm treating a client with an adjustment disorder, and the time and resources that it takes for me as a therapist. But as therapist, I am not required to take all of the diagnosis, or I could choose to have a caseload of just anxiety or depression, which leaves oftentimes clients with more severe diagnosis not being chosen by providers and being left with limited access. And then we talked a little bit about the exam and licensure. And then lastly, before we move to the next slide, is that a lot of gaps in services and programming for step up, step down. So the state of Iowa, you know, has worked hard to have residential types of treatments and then outpatient services. And there's a lot of gaps of the in between. So I can either really have like a 1 time a week therapy session, and then my next option for the level of intervention is I'm living 24/7 in a facility due to the acuity of my symptoms. And we lack a lot of resources and services that live in the in-between for reasons that CPT code doesn't allow it because it's not written into code, and or because of pre-authorizations for it or denials for frequency of services. So as a therapist, I'm seeing a kid who just got discharged from a PMIC. I would love to see him twice a week for individual therapy, have him in a group session and do family therapy. And then also do family without client and do parent teen family type of work with their parents. That would be a very holistic approach to what that whole family system needs, moving from a 24/7 facility to a home environment. But because of that frequency of service, oftentimes that will not be reimbursed due to the number of codes being billed, or pre-authorizations could be required, or flags in place that require me then to do a different additional administrative burden tasks that then push providers away from wanting to do those type of approaches. I would say an incredible barrier and threat to access is the cultural competence of our providers, not by lack of desire and want, but we do not have a diversity of therapists in the state of Iowa, so it doesn't always match the need of those accessing those services. And I think that can be a great threat. We do not, as a state, have a streamlined approach towards screening and assessment to those youth and presenting with mental health. And I would even go as far to saying, right, and I think this is often talked about in the behavioral health care world, is that there's no screening and assessments to even look at from a prevention lens, things that we need to embed into our systems, because there is a fear that if we ask some of these questions and students indicate that they are suicidal or they are having significant mental health needs, if I don't have the services to then intervene, the responsibility and liability that is put upon districts, and that feels incredibly scary. And so sometimes we're not asking those questions, which limits us to being able to really mitigate the gaps that children are experiencing between thoughts and needs and feelings and experiences to the services that can be the right place, right time. Our workforce is a continued barrier and threat in the state of Iowa. There's not enough providers to match the level of need. Similarly, I have explored other states and how they've approached licensing. Not every other state requires that the quote unquote therapist, or what we've deemed in the state of Iowa to be the only provider to offer certain interventions, has to be a master's level licensed past exam provider. And I think for the state of Iowa to expand its access to mental health supports, we have to re-envision who else can offer those supports, whether it's the peer supports that we're starting to create, whether we're looking at bachelor level providers offering other services, just expanding our perception around who can offer a healing experience for youth and families, and how we start to re-envision who can offer healing and connection and belonging and meaning and purpose and a sense of safety for youth that aren't just licensed therapists. Children's service differentiation. So again, I think we struggle in the state of Iowa to try to approach the children's system the same way we approach the adult system, and we can't approach children's services in the same way. we often want to see like a length of service being 12 months or less, but we understand that the brain health of youth changes, their development changes, their brain's not done growing until 25. So for a youth who've undergone continued trauma throughout 0 to 18, for them to need to be in therapy throughout all of those experiences is not that we're not making success in therapy, it's that they've continued to experience mental health struggles throughout the brain development and the brain health of their life. We lack school funding and services within the school setting, and we're requiring teachers and school professionals to often be the frontline mental health providers without giving them the proper resources or support to do so. And there's a lot of varying criteria for access and service provider types and pre-authorization. So a current structure is that we have several MCOs within the state of Iowa who all are then our Medicaid client representatives to our healthcare. And all of the MCOs have different criteria for different things, which can often be confusing for families and providers. Lastly, on this kind of last page here for barriers and threats is that we struggle to have the right time, right place, right service for children and families. They get lost within a system. They may go here for an assessment, but then not be able to access these services. So then they go over here for that. We don't have current databases or systems to have efficiencies within our systems. Transportation for children and families continues to be a large barrier. Administrative burden for providers who are often serving the Medicaid population, high burnout for our providers, continued stigma. And then again, I've emulated this in several different places, but the large barriers and threats to marginalized populations, they're disproportionately impacted through and through, see this daily, youth in poverty, racial and ethnic minorities, and the LGBTQ+ populations. There are differences across the state. There are often local funder initiatives, whether that's county funding or region funding or individual donors that have different pet projects or things that they really want to fund or initiate. And then there's not consistency across the state in regards to that. There are very big differences between urban and rural areas and access to what services are provided, what school can have, and then various differences for school districts. And a lot of that we're seeing that is because school funding can come from enrollment counts. And so your smaller districts that have smaller enrollment often are strained and have to be more creative about how they're trying to approach supporting their students compared to larger districts that may have more funding coming into them. And there's just not equity across all of the districts within the state. In regards to
This
yeah.
is Anna speaking. If we can have you reserve the remainder of your presentation for the Q&A session, your
Yes.
time is up.
Okay, perfect. And this is
Thank
the last
you.
page anyway, so I'll just leave this or close it out. You want me to close it out right now, Anna?
If you could just briefly go through this, and then if members need to if you need you to elaborate, we can reserve that for the Q&A.
Yeah, I don't think there's really much to elaborate. I alluded to this throughout the entire part through the threats and barriers that is always met with some level of advocacy or recommendation. So I don't think that there's anything surprising on this page, and certainly can take some notes and welcome any questions. Thank you so much.
Thank you, Tonya Hopkins, Vice President of Clinical Prevention Services at Tanager Place. Now we'll get to the portion of the meeting where we have the committee question and answer. I'd like to remind members of the public that if you're interested in offering public comment following the committee question and answer session, please raise your hand by hovering your mouse near your name to let staff know you would like to speak. We will also add you to a list and announce your name. We will now move into the question and answer portion of the meeting. We will have a limited amount of time, so please be succinct with your responses, and please indicate if you have a question for a specific speaker or if directed at all speakers. If members have additional questions, I'd like to ask you to use the raise the hand function, and for members joining through phone only, you can press *6 to raise your hand. You may also unmute yourself by pressing *6. I will now call on each committee member to see if you have a question for the panelists. And just give me a second while I pull my screen up. Okay, Stephanie Munsterman, you may go ahead.
Great, thank you. First of all, thank you all so much for your time and your expertise in sharing your stories as well as your experience. I took a lot of notes, and I expect to have many more questions following today. So please forgive me for the multitude of questions I might have eventually. I'm trying to narrow it down. For Anne and other folks as well, talking about the intergenerational trauma of racism and impacts of those and the historical impacts of that. What are your thoughts and other folks' thoughts about best ways to address that specifically, knowing that representation is already an issue as well as access, but just some recommendations around addressing that aspect of it. And I'll just start there.
I'll speak to this. And again, I am grateful for the clinical expertise that's represented in this group. I'm going to speak more from, again, lived experience and sort of that community engagement work to hear and honor stories from others. And one thing that I often share, and I don't have a quick solution, but it's clear that we lack providers overall in mental health. And heard about the rural areas. We certainly, not just in Iowa, but just the sheer representation, if you will, of providers of color or providers who identify as LGBTQ plus, and other just historically marginalized groups. I mean, clearly there's work that has to be done to develop the pipeline, or Tanya talked about licensing. So, I mean, there are solutions. The piece that I do like to remind, though, is building the pipeline and getting the policy change is not an overnight fix. And it's probably not an overnight fix for anything, but one of my fears is that we don't invest enough time, energy, and money in equipping the majority population to understand experiences that may be completely unfamiliar to them. And that's what we heard over and over again in our work group. Whether it's bias or implicit bias or microaggressions. I mean, it's the attitude is, well, I'm kind of used to it. This is just the way life is. But that creates stress. And so I would really love a solution that also helps our majority providers experience it. And there are certainly entities that do that work, but that's sometimes we don't talk about that as much.
Right. Kyle.
And I'm sorry, to be clear, when I say majority providers, I mean white or Caucasian providers.
Kyle Bergeson, any questions?
Not for me. I just want to say thanks to the speakers, and I can yield my time back to Stephanie or anybody else that has a quandary of questions.
All right. And Stephanie, we'll come back to you. Yeah, I'm interested in what you have to say. Paul, okay. Adam Freed, any questions of the panelists?
I do not, but I very much appreciate all the presentations. This was extremely helpful. Thank you very much.
Okay. I think I've called on everyone. So Stephanie, if you have a follow-up, we can entertain. Oh, Donald Roth, I apologize. You were off my screen. I'll recognize Donald Roth.
Thanks, Henry. Can you hear me now?
Yes.
Good. Okay. I fixed the problem from earlier. Thank you again to all of you for the presentation. It's been really helpful. Again, also taking many notes. This question was inspired particularly by Tanya's presentation, but maybe if anybody has any ideas that come straight to mind, I would appreciate hearing about it. I think we've heard from all of the different people that along the way that have presented to us about there being particular disparate impacts, often tied to poverty, race, a number of other factors that are particularly within the sort of core concerns of the Civil Rights Commission. I am wondering if there are any statistics or numbers that people are aware of to help try to quantify some of these type of things. And particularly if there happen to be anything that people are familiar with. I really appreciated Tanya's last slide. That's something I know I'll go back and look at, where there's some specific advocacy tied to it and ideas of what can be done next. It seems to me that if we can wrap our heads around some things that are more quantifiable, that, you know, if there are any interventions particularly tied to some of those things, that may be something I'm really interested in hearing about.
Anyone like to address that? Any of the panelists like to? Okay. All right, we'll submit that to the panelists following the meeting. And Don, did you have any follow-ups?
No, I think that's just kind of been the big question. It sounds like, and if people do come across anything and would supplement and come back to us with any, I know I'm asking a difficult question in asking that one, because there's a lot of lived experience of seeing it and not as much quantification always, but yeah, it's can be helpful in these type of reports that we have to write to be able to put numbers behind stuff.
Yeah, we definitely need that. Right. Stephanie Munsterman.
Thank you. I appreciate that, Henry. Donald asked a question that I had similarly around utilization rates across demographics, but I think it kind of is hitting his question. My question is also related to something Tonya had mentioned around expressive arts and licensure. I'm curious about, what have you seen as the impact of expressive arts not being licensed in Iowa on different communities for, like folks who are nonverbal, but folks who might be, just going through trauma. Are you seeing that causing some issues since it's not reimbursed? Thank you.
Yeah, absolutely. I mean, I think that we have some strict criteria as to what is the licensure status in the state of Iowa and even across state parity. So if someone is licensed in another state, they have a lot of barriers to them becoming licensed in the state of Iowa and vice versa. So there are a lot of barriers in place related to educational status and then how that equates into licensure status based on criteria for what is a reimbursable licensure status in the state of Iowa, which then limits access to those services because then we don't have those providers to provide it because they can't get reimbursed for it.
Right. Stephanie, any follow-up to that?
Not technically a follow-up, it'd be a different topic.
Oh, go ahead. That's
you know me, I don't follow rules well. This would be just a question, I think, for anybody has, and I think Tami, you had mentioned some of your family's undocumented. So, and I know this is across the state, but just the impact of barriers around cultural and language barriers. I'm sure that's another aspect that you might be seeing. If you could speak to that, anybody anecdotally or even quantifiably at some point, but just what you're seeing, I would love to hear.
I can speak to that just a little bit. A lot of our undocumented students obviously don't have insurance. And so we've been fortunate enough to be able to hire one bilingual therapist that is employed by the school. However, he's has to cover our entire district. So he's at the elementary 2 days, he's at the middle school 1 day, and the high school 1 day. The high school has 600 students, over 50% are Latino. And most of those have parents that are only Spanish speaking. And so when we do have additional providers in that are not Spanish speaking, it makes it really difficult to be able to communicate with those families and help them understand what therapy services are and how they can help their students. And if we need to look at possibly medication and other things, it gets just really tricky. So another, really big need for us is just finding therapists that are bilingual. That really helps our community be able to get services that are helpful for them and make them more, I think, comfortable communicating what they're feeling when they can do it in their home language. I don't know if that answers your question, but that's kind of what we're seeing, a high need in the area of needing bilingual help.
If I could add something too, Henry, is that okay?
Yes, you may go ahead.
I think the other thing to consider is that providers have to take, so a therapist has to take a standardized test in order to receive licensure. That standardized test we know is geared towards Caucasian people who come from a middle to upper class status throughout their own childhood. So we see a high fail rate for other populations who could be incredibly healing and transformative and are culturally the same identity as many of the populations needing these services, but are not able to become licensed because of those standardized tests in place. So I just think that's something really important to consider.
Mm-hmm.
Okay, well, I guess I'll ask a few questions. And some of these are abstract and some I may just put in writing following the meeting today, but I thoroughly enjoyed this. It's been very informative and I have lots of questions, but we're limited in time. So I'm going to try to, I guess, triage some of these, but I know several of you talked about incentive programs to get providers in some of these pockets or desert areas. When you mention incentive programs, what exactly are you talking about?
So when I talk about incentive programs, I think not only for rural areas, but potentially to be credentialed with a lot more insurance panels, to take clients with more varying diagnosis. Like there is no reimbursement differentiation for any of these things. So even if I'm rural, I get reimbursed the same fee for service for a CPT code of 908-343, so 34, which is like a standard 45-minute therapy session. It's reimbursed the same regardless of how many years of experience I have, regardless of the diagnosis of the client, regardless of the place of service that I'm offering it, regardless of how long that client has maybe waited for services, the varying needs that they have. So there's no differentiation in that. And so providers are often then not very incentivized to offer services to more complexity and or in rural areas because there's no differentiation.
Okay. Anyone else? I thought someone else referred to incentives as well.
So we've had a really different, obviously because our piece of it is not sort of the service with Tanager, but we talked about even in rural Iowa, could we do something to make housing more affordable so that it would attract graduates? Are there things we could do about tuition reimbursement to make Iowa more attractive or to make some of those rural areas more attractive? The other thing, which is not directly related to your question, but I just want to talk about is a little bit when we talk about pipeline, what we're seeing in education is one of the ways we're addressing pipeline is to reduce qualifications. And that is something I worry about for providers that I think we need a high standard of qualifications and expertise. So I was really intrigued by the testing issue that Tanya just talked about, that is screening some people out. So instead of just saying we are going to get rid of that, which is not what she was suggesting, but I just have watched how legislation has impacted the field of education. I wouldn't want it to be that we have no criteria. I would want it to be that we have criteria that is more inclusive of multiple providers, and is getting high quality providers a chance to practice in the state of Iowa.
I'll continue on. All right. So I'm new to this. Is there somewhere we can go to get a list of the universe of groups that are out there that service K through 12 individuals? And then along with that, is there room for collaboration?
So I'll say, I think you've hit on exactly one of the challenges. Is I don't think there is kind of a one-stop, resource for providers of K-12. And I do think that the system could be enhanced by more formalized collaboration across just across organizations. What we heard about Tanager Place, that's kind of a Cadillac of service delivery in that area. And so when I think about how would we try to bridge that in some of our other areas, I'm not even sure how we would do that. And when I think about crisis and kids in crisis getting transitioned back to K-12 settings without a lot of support, we don't really have a good system that connects either for program development or service development, or just service of individual students. So I think that's something that could enhance our system.
Okay. And then searching for some, and I think Don hit upon this, searching for something quantifiable to document these pockets and deserts. How do we identify where these pockets and deserts exist? And is there like information out there that shows us ratios that perhaps in an urban area, it's 1 counselor to 30 students, in a rural area, 1 counselor to 40 students? Does anything like that exist, or do you all know where these pockets are?
My response to that is all anecdotal. Today I was meeting
Yeah.
with a district. They have not been able to get a service provider. They've contacted several private companies. And even in the case of this district, they had 230 kids who needed individual service last year. And there was nobody who was able to match a provider to that area because of the insurance and the billing and what their, what their cost benefit ratio was going to be. So I guess my experience with it would be anywhere outside of the Des Moines area, the Iowa City, Cedar Rapids area, and the Quad Cities. You're pretty much looking at some kind of pocket of no service being available.
And what are the consequences of not provide? What are you all seeing as a result of not providing these services? And we can even break it down into the specific demographic areas, if you like. In urban areas, rural areas, among race, among the LGBTQ plus community, among impoverished individuals and wealthy individuals. Can anyone speak to that?
One thing that I've seen at our school is our students who struggle the most with mental health are also, for the most part, our students that we see our biggest attendance issues with. So when they're struggling and not getting the support that they need, they have a tendency to not come to school, which creates additional issues for them.
Yeah, I mean, my comment was going to be death. I don't mean to be dramatic, but kids are killing themselves at higher rates that we've ever seen. And it gives me goosebumps and it makes me emotional. But we are seeing mental health on the rise. This is not changed. The 10 point and the forecast of this is not changing. It is increasing. The prevalence is more, the symptomology is greater, and it is resulting in more lives being lost, and access being more and more difficult. And so we know that those being most impacted are those marginalized populations. And exactly as Tami said, one of the things that I believe that is the greatest pathway to hope and resilience and possibility for students is their education. And when we are facing mental health struggles, we are disengaged often. And then so it is creating a myriad of other complications and struggles. And so we now are having significant mental health needs. We're disengaged from our education, and we are increasing the correlation then to generational struggles.
And we have time for 2 more questions. I'll extend that to the other committee members. If not, I have one, but I'm gonna monopolize the time unless I'm given an opportunity to do so. Oh, Stephanie, go ahead.
Thank you again for your time and your answers. And it is heartbreaking. I'm sorry, I'm a little short on words for a moment there, and just thinking about the impacts of this. And it cannot be understated how important this topic is for our kiddos and their adults at home. My question is for Cindy around, I'm not going to go into the current legislation stuff around AEA. You're like, please don't, because I know that's going to be really, really challenging. I am curious. I know when folks have, the IEPs, and we also know sometimes educators or folks don't always follow IEPs. I'm curious if you see that as, in your experience, as a lack of support for the educators or lack of training. What do you think that gap that you might be seeing in there?
So you're asking specifically around when IEPs aren't implemented as they're written, is that?
Yes.
Yeah.
Yes.
I think, I think there's a myriad of reasons. I do think one potential area is lack of training, lack of resources. I also, just a quick statistic for you, we have 535 teachers of special education who are teaching who received a conditional license this year alone. So across our state, there are 535 people that are teaching special education who have had no training in special ed prior to walking into a special ed room last fall. So, for us to think that they were well equipped to implement some of those IEPs would be erroneous. I do think there's a resource issue, and there's a high burnout in special education teaching. So, and there's also within one special education room, you might have some very different IEPs. And so so as I say, I think there's a myriad of reasons. I do think it's about support and education for teachers. And it's one thing we're just really always concerned about, and trying to figure out how you get more resources in around the teacher so they can help better serve the kid. But there is a gap there.
Okay. All right. Anyone else have a question? Comment? Okay. So I did notice in this panel and the last panel, there was at least several mentions of this issue of cultural competence, where it's important for the provider to understand the identity of the person that he or she is serving. And we'll ask the same as the last panel, if you all can provide any research to substantiate that, that would be much appreciated. And then can we put some demographics on that? What identities do you think are really lacking for the K through 12 clients? Or maybe I'll put that one in writing. Okay, thanks. Oh, Ann Harris Carter, did you start?
I'm going to need to look up, but there are a couple of studies and practitioners that come to mind that might be helpful.
Great. All right, so this has been most informative, and I want to thank you all for taking time to appear at this hearing today. We will now, and any of you have any final comments you wanted to say anything before we go into the public comment session? No. All right, thank you. We will now go into the public comment session. This is an opportunity for the public to offer comments to the committee about this topic. And Anna, do I go on if there's no folks from the general public here?
No, you don't have to, Vice Chair. No members of the public have joined.
Okay. All right. So skipping ahead, once again, I want to thank everyone for joining us. We appreciate your time and look forward to having you all join our next web hearings, or keeping in contact with us and following up with information. Members of the advisory committee, please stay on for a few minutes for our business meeting. Everyone else, please feel free to stay on and join the business meeting, or otherwise, please enjoy the rest of your day. But I do want to have the committee members thank our presenters for today once again. And we have Ann Harris Carter, Health Equity Program Manager at Linn County Public Health, Cindy Yelick, Chief Administrator at Heartland Area Education Agency, Tami Valline, High School Counselor at Perry High School, and Tonya Hotchkin, Vice President of Clinical Prevention Services at Tanager Place. Thank you all so very much.
Thank you.
And then committee members, please stay on. Right. Are we set?
Yes.
Okay.
Mm-hmm.
So for the business meeting, review of a project timeline, Anna, I'll let you address that.
Yeah, I think at the last meeting, Victoria reviewed it with you all, but if not, I have a slide here just kind of identifying where we are in your project. Today was your third web briefing. I'm hoping we can have a discussion about your fourth web briefing and when you would like to hold that, along with specific speakers that you were thinking of, or organizations that we could reach out to that could get us closer to those speakers. Following that fourth web briefing, I'd like for us to have a debrief of testimony, just so that you all are on the same page about the information that you heard, what data might be missing, generally just what other information might be missing, and that would inform of whether you would like to hold a fifth web briefing potentially, or where else you would need to, I guess, look around on the internet to find publicly available information that would make your report, that would support some of the testimony presented. And so I have here just an estimate of when the official record would be closed. It would be early summer or late spring or early summer. I don't have specific months, but it really is up to the committee. And then following that, we would start with our report stage. which would be in the summer. Oftentimes it takes about four meetings to review drafts of your report. And that is in collaboration with some of the speakers, just to ensure that their testimony is accurate and that we've accurately summarized their testimony. And then following that, once the committee has completed the report, we'll submit it for a legal sufficiency review and a degrade and defame review. And if all goes well, we'll be able to release your report in the fall of 2024 or early winter of 2025. And then we can discuss if the committee would like to have a post-report activity. Sometimes committees like to release an op-ed or hold another kind of webinar where they announce some of their findings and recommendations and invite the media or other stakeholders who might be interested in listening in on the committee's findings and recommendaps.
Okay.
It's essentially a way for you to raise awareness about your work product and just inform folks of this project generally.
Okay.
And so that would really just depend on where we are, your enthusiasm, your sort of your availability and your schedule. And it's not required to have a post-report activity, but it is an option for committee members that would like to have sort of some closure with their project.
Okay.
So
I think I do remember us discussing this timeline the last meeting. I don't think people had very many questions. I think the big thing we need to discuss and is the need for a fourth hearing. And I think from some of the questions that some of you asked, I think there's a concern about not having a lot of, having a lot of anecdotal evidence, but not necessarily some data. And so I guess the question, we only have 3 people here, so maybe we'll have to respond offline somehow. But do we need more data? And then if we do we need more information? And Juan is probably be the one to address this, but I'm just putting it out there. Do we need some things that we should consider is whether we need more information to really develop, our topic, and then B, will a fourth web hearing get us there, or are we looking at research that we need to do? And then if we do believe we need more data, then maybe we need help pinpointing to the targeting the people that can provide us that data. And those are just some comments that we should think about. Juan's the chair, and so I don't know if anyone else had any comments.
I would agree with what Henry said there. I think we knew that this, from talking, with a few different people and stuff, it seems like there's clearly an issue here, but identifying what it exactly is within the scope of what we're supposed to be doing as a state advisory committee, and what are the best, I think both in terms of practical and most effective, interventions to recommend or things like that. It's just a lot of things to try to wrap our head around and try to get some specificity, and numbers would really be one of the biggest, I hope. I mean, it could just be that the numbers aren't out there, but something that helps give us some of that focus that we need would be really helpful.
Yeah, and maybe that's one of the things we identified, because I just don't know how we address the issue without having numbers to back up the picture, the percentage of students in some of those demographic areas needing services, and then some sort of information on the ratio of the providers to students needing services. And that information may not exist. And maybe if it doesn't exist, maybe we can ask enough questions that maybe one of the organizations would put that together for us, or maybe collaborate.
There are some reports out there. Oh, sorry to interrupt. There are some reports out there that I have come across in my work Like the Trevor Project does quite a bit of really good work around this topic explicitly. Their focus is LGBT community and mental health youth. But there are other reports that I can dive into and share as well. I agree. I mean, I'd like to have those numbers like utilization rates, demographic, or the food deserts, and to Ann's points, and I've seen those maps where you see the redlining and it does just lay perfectly across where the life expectancy is shorter, and for just one example, and I know I've said this a few times and you're probably tired of me saying this, but I really, I really think it's very important if we're going to be studying youth to have a voice of the youth at the table, recognizing that, it's, we just recognize that we can be very careful with that. But I just think it seems a little bit, this might be a little harsh, but it seems a little disingenuous to study youth without listening to youth. So I would just like to express that again.
No, I agree. Yeah, the issue is, I think the question that came up the last time is how do we go about doing that? And we forgot to ask that question of the panelists again. But yeah. And I don't think we can do much without Juan being here since he's the chair. So I don't know what the next steps might be, but we need to decide.
I think the one thing that I would like to hear from the committee is if there is interest in holding a fourth web briefing.
I have interest because I think there's some voices we should still hear from.
Yeah, that's true. Yeah, to hear from.
And we do have a quorum, so if committee members would like to vote, we can certainly do that. And then I can get started on offering a couple of potential panelists, or try to get other members to contribute ideas offline.
All right. Is there a motion to hold a fourth web hearing?
So moved, Stephanie.
Is there a second?
Support.
All right. We have a motion, we have a proper second. Any discussion? All right. Seeing none, all in favor, please indicate by saying aye.
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 All opposed indicate by saying nay. All right, the motion carries. Anna, is that what we need? And then I think along with that, like I said, I think it's important that we maybe even individually pinpoint, the information that we would need individually, and get that to Anna, and perhaps that would help her get some indication on who we want to talk to at the fourth hearings. I would hate, to have the fourth hearing and still be in the same spot where like, well, that was nice hearing the anecdotal information, but we really don't have the substance that we need for the report. All right. And anyone else like to be heard? All right, seeing none. Anna, any final comments, or Corrine?
Yeah. So I will send out an email to the committee, or actually I'll speak with you, Henry, and Juan offline to get some dates to hold a fourth web briefing so that we can have it on our calendars, and that'll help with conducting outreach. Where we are right now, we're at the end of May, so it's likely that we'll hold a web briefing sometime in mid-July, just because, we need some time to conduct outreach, and possibly have a meeting before holding that web briefing, just so that folks are aware of who you're going to hear from, and obviously vote on who you'd like to hear from. Yeah, so expect an email from me or Corinne rather, with a link to a poll, so we can get your availability. I'll send out the money.com board again for you all to contribute any ideas for potential speakers, or even ideas on organizations that can get us closer to a potential speaker. If you have questions for panelists, please send them to me so that I can send them those questions in one email. you'll be able to, review their responses all on one document once I receive all the responses. I think that is pretty much it. I am updating your webpage with all of the information from the presentation slides, the transcript, all of that. So that'll be useful once we start doing our debrief as we get closer to the report stage.
All right.
Yeah.
All right, nothing else for the good of the order. I think that will conclude our meeting. And I guess Anna's going to be in touch with us. I don't know what my final comments are.
Thank you for your work, Anna.
Yeah,
Appreciate
absolutely.
it.
And this is the exciting topic. Thanks for bringing this up, Stephanie. I'm really enjoying this topic.
Oh, no, it was group.
All right, everyone. That's all I have. I guess the entertain a motion to adjourn.
So moved.
All right. All in favor, please indicate by saying aye.
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 All right, ayes have it. All right, see everyone the next time. Bye-bye.
All right.
You.
Have a great